You have sleep apnea. You're stopping breathing during sleep multiple times per hour. And when you stop breathing during sleep, two bad things can happen, and they're both happening to you. The first thing is that you wake up. You have to wake up, or at least get kicked out of the stage of sleep that you're in, to start breathing again. So you fall asleep, stop breathing, wake up, fall asleep, stop breathing, wake up, and that takes a toll on your brain and on your heart, and it impairs your vigilance. That is a risk factor for driving, and I'm sorry to have to tell you that you're at risk for a car crash because of this condition and the sleep disturbance that you're having. But the other thing that can happen is that your blood oxygen level can fall. And when your blood oxygen level falls, your brain, which is pretty important, and your heart are starved for oxygen. And the consequences of that include high blood pressure, stroke, atrial fibrillation, congestive heart failure, and death. So if we could just keep the back of your throat open when you're asleep, the air could get down there and your lungs could do their job. And I generally say at this point, if their lungs are good, and very often their lungs are good, right? It's an airway problem. I say, your lungs are perfect. We just need to get the air down there so that your lungs can get the oxygen out of the air. And, wait for it, CPAP, which stands for Continuous Positive Airway Pressure. I say that so my patients won't talk about CPAC. Blows a moist, gentle stream of air through your nostrils, or through your nostrils and your mouth, however you prefer, that simply, gently, and effectively splits open the back of your throat so that your good lungs can do their job. I do not think it is appropriate to tell a patient that bilevel pressure is effective for sleep apnea. The data there are simply lacking, or at least more effective. It might be as effective, cost twice as much, right? So I don't think we have data to support telling a patient that that's an alternative. And some of the other treatment modalities have not been shown to be more effective than CPAP, although they all cost more. Now there is a viable alternative to positive airway pressure. Oh yes, oral appliances made by dentists. These have been shown in randomized controlled trials. The dentists have gotten their act together, and they have clearly demonstrated that oral appliances improve oxygenation, lower blood pressure, and reduce sleepiness. Way better than placebo. And by the way, way better than upper airway surgery. They just don't do it quite as well as CPAP, but they are way better than nothing, which is what the patient who cannot or will not use CPAP is going to get if you can't offer them this alternative. Let me also say that we know that for the patient who has a weight problem, weight loss can be curative. In a patient with mild sleep apnea, a 10% weight loss can cure mild sleep apnea. And let me also say that we have good data now. I mean, we had signals, we had observational studies, we had case reports that people on CPAP tended to gain weight, but now we know from a randomized controlled trial that people who have sleep apnea and use CPAP gain weight, at least for the first 6 months. And the more they use their CPAP, the more adherent they are, the more weight they gain. This has changed my thinking and has changed my approach to the patient with mild sleep apnea. If a patient does have mild sleep apnea and does not have an immediately life-threatening condition like severe sleepiness, which could kill not only them but also you and me if we're on the same road, and if they're not terribly hypoxemic, then perhaps the way to go with these patients is to recommend weight loss first. You know, in medicine we're way too often, way too quick to jump to, the bullet that we have in our gun without giving the patient a chance to use his or her own power. So for people with mild sleep apnea, I try very hard to get them to lose the weight first if they don't have any, and the important caveat is, if you're on 4 blood pressure medicines and your systolic is still 180, probably need to go on CPAP today. So it depends on, again, you have to be a doctor. So weight loss. And to carry it a step further, you know, when you tell a person to do something, you need to give them the tools to do it. My experience and my reading of the peer-reviewed literature is that Weight Watchers is the way to go. Full disclosure, I've never worked for Weight Watchers. I don't consult with Weight Watchers. Nobody is paying me to say this. I have used Weight Watchers from time to time in my own life to just control my, issues. I think that pulmonologists will take sleep apnea back. Yeah, and we need to. It's an important, well-defined disease that's deadly and has an effective treatment. Some other sleep disorders are not so well defined. It's not clear that they even affect the patient in a meaningful way, and it's even less clear that our efforts to treat them will improve patient outcomes. But we have a disease right in front of us that's undertreated, and we need to go for it. Always new treatment methods coming. You've probably heard about hypoglossal nerve stimulation, which is an implantable device. It's a surgical procedure, and it is FDA approved. Still some insurance difficulties. It's a big deal, and one limiting factor for this condition is that it can't be applied in people with body mass indices over 32, which is kind of a minority of my practice of sleep apnea patients.